Yeah, so doctor, I think if you could describe the current healthcare industry in one sentence, what would it be?
Okay, fragmented and confusing.
Fragmented and confusing.
Yeah.
I see. But when you say fragmented, what do you mean by fragmented? Is it like a problem?
It's too many stakeholders with all their own interests that is actually trying to fit their interest to actually deliver the healthcare product.
Right.
The problem is everybody's got their own, I won't say vested interest, but I guess say their product offering actually has got a lot at stake in terms of wanting to offer a product, but at the same time making sure that it is sustainable. At the end of the day, nobody wants to be burned by offering such a solution and offering.
And the other day just yesterday, I spoke with Dr. John, who is an ophthalmologist. I'm not sure if I pronounced it correctly. Ophthalmologist, yeah. Yeah, so Dr. John is actually a classmate of Dr. Tim as well. So we done an interview, a live session on Instagram, and he said that Malaysia's healthcare is sort of like a sinking ship lah. But there are things to be done. It's just that, we could be better lah, what he's trying to say. So do you agree with this sort of thing?
Oh yeah, completely agree. Because I think the issue here is basically we all want to have a good healthcare delivery system. And the three components I always talk about is efficient, good, as well as cheap. Now those three things sometimes do not meet. Most of the time you can get good healthcare, you can get fast healthcare, but it's not cheap.
Yeah.
And sometimes when you can get good healthcare and something that delivers, but you have to wait for a long time. That's where the public healthcare system is at the moment. So I think trying to bridge the three quadrants here, to the three issues here, to make sure that we are able to deliver good, efficient and fast. At the same time, it's affordable. It's something that is, the balance that we're trying to...
That's the challenge lah.
Yeah. That is a challenge. The reality of the situation is healthcare is expensive. That one, we have to put it right on top to say that, look, the delivery of healthcare is not going to be a simple solution, it's an inexpensive solution. We have to understand that reality is, it is very expensive. I'll just take an example, for example, cancer care, right?
Right.
Now, cancer from what it used to be, it used to be a diagnosis that is associated with nearly 100% mortality. Your diagnosis is cancer, there's no hope for you.
Yeah.
But now, with so many advances, early surgery, early detection, early screening, and then we are going into molecular levels of treatment, targeted therapy, immunotherapy. Now, all of this have actually given patients a good shot at extending their life. However, because it's so... the technology that is there to actually come up with these solutions, to begin with, the R&D involved is not cheap. So you have to have a lot of investment made in those kind of technology, those kind of scientific advancements to actually come up with a solution for that. So people have invested, like for example, the pharmaceutical companies, they invest. So they obviously will expect some kind of returns. And to be honest with you, not all the solutions made by the pharmaceutical industry work. For example, just off the top of my head, maybe 100 solutions they come up with, maybe only one or two will pass the second or third stage of the clinical trials and be useful for the patients. So all those investments made on things that don't work will have to be absorbed as well. So in order for these kind of R&D investment to be made, they will need to have some kind of return of investment as well. So I guess to begin with, a lot of these research are expensive. A lot of the solutions that come out with are expensive.
Yeah.
But once it reaches the end user, that is where the cost factor comes in, because the end user will be now given an option of having this solution. So say for example, those days we never used to offer targeted therapy because that is very expensive. But now we are able to give that to the patients, but it also, of course, it comes out with a very big price tag, and not many people afford it, so that's where they end up not taking up those kind of solutions.
Yeah, I guess the thinking that Malaysians have is that it's probably maybe veering towards a bit more privilege, because we believe that healthcare should be available for everyone. We want it cheap, we want it fast, we want everything,
Yeah.
So
That's where I think the role of the government is very important.
Right,
The thing
right.
is, we have talked about national healthcare financing. Now that's this. I would say that is the one single most important aspect of the healthcare delivery system in Malaysia that is often spoken about but not discussed in detail, or is discussed in detail but it's not crossed over the finish line. And the thing is, it is as a concept we all agree that some kind of a different form of healthcare financing needs to come in place. Whether it's at the moment right now it's fully taxpayer funded. Whatever that we get from for the public healthcare system is more or less taxpayer funded.
So in a way, Malaysians are paying for it, lah.
In a way, they're paying for it, but it's not enough. So, for example, the GDP, I mean, they used to say that 2.4% or 2.6% of GDP is currently being allocated. What is recommended is about double to 5% or something like that. In fact, in some countries, I mean, let's not look at US lah. US spends nearly, if I'm not mistaken, 17 to 18% of their GDP on healthcare. That's too much lah, and that's why it's so expensive. A nice figure to look at is probably around 8 to 10%, but we're not even at 5 yet. So the thing is, why aren't we pushing the level of investment from the government towards about the magic figure of 5% first, and from there you can slowly inch our way up 6-7% overall over the next few years. But see, the thing is, it is a very I would say it's a very political in the sense that getting the public to fork out more in this present day and age it's difficult. But having said that, somebody has to bite the bullet and make that call, because this 1 ringgit, 5 ringgit business is not going to be sustainable. I mean, I admire the way the Ministry of Health is doing their work. They want to give the best healthcare kind of thing, but in order to deliver it, your long-term plan, it must be sustainable. You can't have, say, 42 billion allocated as a budget for healthcare, and then come May, June, July, you're running out of budget, and the rest of the year you can't really provide decent delivery of healthcare. Waiting time to get a procedure done is long, and it's all a very cumulative kind of effect. I mean, in order to deliver the healthcare service in the system, you need to have good doctors, good nurses. And they get frustrated, they leave, and then they end up becoming a vicious cycle of people who are being trained, and then once they're trained, they're barely senior enough, they leave.
Yeah,
Because
exactly.
there's not enough of promotions and not enough career prospects and whatnot. So I think I'm not in the government service anymore, but I do have good friends within the system, and I can understand what they're trying to do. Like they're trying to their level best to deliver, but see they have to have the maximum support from the government to do this, and I think that's where you and I can talk about it. But the gatekeepers for the politicians, they need to actually come across with that proper financing scheme to actually push it, and then once they have that in place, then the private sector can come in and complement. Now, the thing is, what is happening right now is we are being ostracized and being blamed for something that is completely not our fault. You see, the reason why private healthcare is actually, to be honest with you, it's meant to take care of people who are in the private healthcare system. Those who have private healthcare insurance, those who have a need to come and via their corporate insurance or employer insurance or whatever, we're supposed to take care of that, so that the remaining 70% or 70 or 60% of patients who are falling under the government healthcare system will still be able to access the government healthcare system. Now, what's happening right now is the dropouts are quite a lot now. The people are not willing to pay for their premiums and pay for the insurance and whatnot.
Yeah.
So they are now flocking to the public healthcare system.
Yes.
And that is already straining and overstretched public healthcare system. Now, if you look at why this thing is happening in the private healthcare system, I think if you speak to the insurance industry, they will blame on the medical inflation.
Exactly.
Right?
Yeah.
Right. But if you speak to us in the industry, in the healthcare system, for example, the doctors, what we have charged in 2013 and what we are charging in 2024 remains the same.
Yeah,
There's no change there.
exactly.
No change. Right? But having said that, the technology and the advancements in terms of the medication, the surgical access, the surgical instruments, surgical equipments, that has not remained static.
Right.
So even in the space of 10 years, what we used to do in 2013, for example, just one example, prostate surgery, cancer of the prostate. It used to be done via open method, very debilitating blood loss and whatnot. Now it's moving more and more towards robotic surgery. Now, robotic surgery for cancer of the prostate is now becoming the mainstay of therapy. But in order to purchase a robot, you need to invest in at least 8 to 10 million ringgit for you to bring that robot into the country and to actually train your doctors to actually do it. And so many of the hospitals in the Klang Valley and Penang and all, they have invested in robotic system to bring it in. So the same thing can actually be provided by the Ministry of Health, but the Ministry of Health is only limited by the amount of funding they can have towards robotic surgery service. So when you do not have a budget to allocate to buy these robots, the private sector takes on itself to buy it. I mean, the private sector invests in this to bring it in.
Yeah.
So they need to now recover the cost of providing that care, and that is the reason why certain surgeries are being done in private hospital, which is a little bit more expensive than the public system. Because the private sector has to invest, they have to have a return of investment, and most of these equipments and all take about 5 to 10 years before they run out their maximum use, and then you have to keep replacing it again and again. Now, the robot is just one part of it. There are disposables that are associated with
so many other things, right?
Yes, so the robotic arms, the devices that are put in, the suture materials and all those things need to be actually bought and used, and most of the time is single use as well. So that is why certain procedures are expensive. And if you don't actually provide the patient with an option of taking on this kind of work, and say for example you were to go back and say you do something really basic and archaic and it's not considered a standard of care, then the doctors will potentially be facing a situation where they may be asked, doctor, but this option was available, why wasn't this?
Yeah, why? It falls back to the doctor again.
Yes, why didn't you do this for me? And because you didn't do this for me, now my cancer has spread everywhere. So you are now liable, and you didn't offer, or you didn't refer me to a center that can do it or whatnot. So these are the dilemma that doctors in private hospitals face. The private hospital also, they are not funded by taxpayers, zero from our budget, our taxpayers. So they are basically privately funded, private investors come in and set up the hospital, and I can't quote them, but I can say for sure that for the first 5 years of you investing in a private hospital, your returns are actually very minimal. You know, you're actually basically you're trying to recoup the infrastructure, the investor, the equipment, manpower, the human resources, everything. So you're even the first 5 years or so, you're just trying to level your best to actually get some kind of a revenue to actually make sure that at least you meet your operating expenses. And after the 5 years, 10 years, then you're looking at incorporating all this investment. So the thing is, the public need to understand that, you know, setting up a hospital in many parts of the country is initiated by the private sector. So I'm actually proud to say that, you know, Johor right now, even areas like Batu Pahat, Kluang, Muar, these are all areas that previously relying only on government support. But now there's actually hospitals going in there as private hospitals to actually complement and add on to the healthcare delivery system. So if, say for example, if you are in say in Kluang, for example, and you have a need to have a cardiac surgery or a cardiac catheterization done or an ONG surgery done or whatever, you can also access private healthcare as well. That relieves the KKM or the Ministry of Health to actually focus on the patients who cannot, and the middle income group can actually access. So these are the things that are actually an advantage, because now in the early 80s, when private hospital was nowhere to be seen, people used to be going down to Singapore and to UK and to England to get surgery and operations done, and those are actually basically people who can afford it, who can have the cash, who are willing to pay 3 times more time, 4 times more just to go and get treatment done. But what private hospitals have done is they have made access to modern healthcare accessible to even the uncle who's char kway teow goreng uncle in the stall somewhere.
They've bridged the gap lah.
Yes, they bridge the gap. So these uncles used to be, last time all they had to figure out how to go to Singapore, right, to go and get the treatment. Now it is actually now in the doorstep already. So what we have done is basically, now this uncle, he needs to get back to work as soon as possible. So even for example, a simple surgery like an appendix or gallbladder surgery or a kidney stone surgery. Now if you put yourself in a public hospital setting, you may sometimes get a date of 6 months to 1 year before you actually have access to.
That is the
your
waiting
surgeon.
period, huh?
Yes, that's the
Wow.
waiting period. Sometimes it can be that long. So if you, unless it's an emergency, but most of the time it could be delayed to that aspect. So for the duration of 3 to 6 months that you're waiting, you actually, say, could be in pain, you can be miserable, you cannot. So you're not actually functioning enough to actually get back to a earning capacity, right?
Yeah.
You're on and off in pain. But what private hospital does is, you come in, you get it sorted out within a week or two, you're well, you go back to productivity. I mean, you go back to your economic productivity, and you can earn the money back,
I guess.
So that, I think it's the biggest advantage. Yeah, go ahead.
I guess the other aspect that Malaysians aren't really seeing, including myself, because apologies for being naive. My previous thinking about private hospitals is that they could charge however much they want when it comes to equipment, right? But when it comes to doctors' fees, that one is regulated. So that leads me to think that, hey, maybe one of the sources of insurance premiums increasing is because private hospitals are charging much more than the original equipment. Yeah.
Correct. So that comes to, that's one aspect that we talk about, which is unregulated.
Yes.
So the unregulated portion is what we call the HSS, the Hospital Supplies and Services. Now there is some truth. There is some truth to the aspect of the say, for example, the equipment that is brought in. There's always a markup. The markup is actually now. The ranges I can't say for sure, but why is there a markup? There is a markup because you have to factor in all the other hidden costs that is actually for you to deliver that healthcare delivery cost. Now, it is not about the 300% or 200% markup. It's not about that particular equipment price alone. That equipment price itself that is being marked up consists of various other facets of the hospital cost that is actually embedded in. So sometimes I do feel that, it's a little bit like, when you see the itemized bill in your hospital bill, you then look at it and say, wow, the nurses come and see me for once and then it's a 40 ringgit charge.
Yeah.
Or why the vital sign monitor.
Sterile gloves.
Yeah, sterile gloves and whatnot. So there's a lot of these things that are being... So the markup is actually one way of us trying to monetize and make sure that we also capture the hidden and the cost that is not revealed to the patient. Now, I'll give you one example of, say, for example, electricity bill of running a hospital. Now, where do you put that in the patient's bill?
There's no way you can say, I'm going to charge you for electricity, right?
There's no way you can put. So where do I put the charge of a cleaner that comes to your room and to clean and whatnot?
There's so many layers.
Where do I put the charge of the cook and the auntie who's cooking your meal and your diet and whatnot? So there's a lot of these things that actually you can't really put it in, but you see, so like when a menu comes to you and you have a chicken chop, or for example, the chicken chop may be 50 ringgit, but you can actually argue and say, hey, why is this 50 ringgit? It's actually supposed to be only 10 ringgit or 15 ringgit in the mama shop outside there. So, I mean, those are the arguments that people actually do not understand, that we have to actually embed a fair bit of ongoing expenses, including the staff costs, the utility bill and all the other things. In fact, even medical legal, for example, the hospitals have to take on big insurances now to actually pay for their premiums, to make sure that for litigation purposes they are also covered. They are covering their staff, they're covering the doctors who are employed by them, they're covering the pharmacies, the lab, the blood bank staff and all those things. So there are all of things that the hospital has to take care of that cannot be put in as an itemized bill in your bill. So that is where the markup comes in. But you see, having said that, the hospitals also within a certain district, for example, you look at Klang Valley, you can't really mark it up beyond a certain level too high that you're pricing yourself out of the equation. Now, just give you an example. Let's say Hospital A, they do a knee replacement for 35,000 ringgit, and it's the same prostheses, same surgical expertise, same
quality, everything.
Same quality, the delivery of say 3 to 5 days stay, whatever. And they are able to be for 35,000. Say Hospital B, same thing, the device all the same. They're putting at 45,000 or 50,000, let's say, I'm just giving you a figure. Now, if a consumer is smart enough, he will do his investigations, especially for a knee replacement. Because it's a very elective kind of procedure. You go around, you shop around, you look around, you speak.
It's a free market.
It's a free market, and you choose where you want to get the surgery done. Now, if you choose to do in a hospital that has got too high of a markup, and you feel that this is a bit too much for me, and I'd rather go to this surgeon who's actually charging this amount of figure, that is purely your prerogative. You have to actually do that, and then you do the research, and then you go with what you're comfortable with. And most of the time, what the hospitals will then find out is, if, say, for example, along a period of time, they've invested in everything. They got the devices in, they got the robotics in, but they priced themselves out so far from the competitor that they only do 1 or 2 cases a month instead of doing 10 cases a month. What will the hospital do? They will naturally
have the lower prices.
Yes, to actually compete or be competitive enough so that they know that on average the offerings is about the same. There's only a certain difference because they're able to actually pay for the additional, aesthetics of the hospital, for example. Now, for example, if you may go to a 6-star kind of a facility, or you may go to a 3-star, 4-star kind of facility, would offer the same thing as well. But you're not paying for all the extra frills,
Sorry for interrupting you, doctor. Because an idea just lighted up on my head, So the solution to this is not to regulate the prices of private hospitals, but rather to solve the issue with public hospitals first. To ensure that public hospitals have enough government funding to ensure that the quality that they deliver is not to say on par with private hospitals, but at least, let's say, 70 to 80%. So that, Malaysians will be able to go there for healthcare and at the same time have multiple choices when it comes to private hospitals.
Correct. So I think there are 2 approaches that we need to look at. Number one, the public healthcare. What we need to do for public healthcare is, like what you said, increase the budgeting, increase the revenue, increase the financing for them. Now, the way I go about it is basically what is happening in Australia right now, which is actually, to me personally, in my view, that should be the system that we should aim for. Now, in Australia, it's all 100%. I mean, there are a few components there. There's public healthcare delivery system is actually the primary main of providing healthcare, and they have pockets of private hospitals who are actually supplementing the work of the public hospital. In fact, you find that some doctors, they work in 2 places. They work in both the public as well as the private healthcare system. Now, what happens is Medicare, which is the taxpayer-funded kind of thing, they will take care of all the relevant expenses associated.
This is like Singapore, isn't it?
Singapore has got the CPF, Medisave.
Yes.
The CPF, one of the things, Medisave. There are many things like that. Now, in Australia, what happens is the private hospital have a charge. I'm going back to the knee replacement story.
Sure.
They have, say, for example, 45,000 Aussie dollars in knee replacement charges. Now, if you go to a public hospital, you can still get your knee replacement done under Medicare, under the public hospital, but they will provide you the say, for example, it's fully funded, but you may get a knee replacement done 6 months down the line or 1 year down the line, right? But you have to wait. But if you feel that, look, I'm also a medical card holder, I want to actually exercise the option of bringing myself to a private healthcare facility that has got a good surgeon, but they are paying 45,000. They are offering me this knee replacement for 45,000. My insurance company's arrangement with that hospital is for 20,000 Aussie dollar, and I can use, say, 10,000 Aussie dollars from my Medicare, Medisave fund or whatever. So you now have 30,000 that you can actually access in that private hospital. And the balance billing, we call it balance billing. So it is a financial discussion that takes between the patient and the hospital. So your balance billing will come from you topping out that out of pocket another 10,000.
The difference,
done. Yes, correct. So that is actually the system where everybody's happy in the sense that, look, you have the option. If you want to wait, you use your taxpayer money and you wait in the public healthcare system. But if you also have a company that has insured you, and this company has got a policy that you can use to access private healthcare for, say, 10,000 or 20,000 is negotiated, your 20,000 from there plus what your Medisave is going to give you and what you are willing to pay, and you get your surgery done. So that, I think, would be an ideal way of moving away. Now, what happens in Malaysia right now, we have an either-or option.
Yeah,
You
either
go
or.
to a public hospital or you go to a private hospital.
And claim your insurance.
There's no collaboration that takes place in
Yes.
between. So I think that is the conversation that needs to take place in terms of how we're going to do it. We had that during COVID, where we utilized private hospital facility to take care of public patients, and there was a negotiated discounted rate that was given by the hospitals to the public hospital side. But because at that point in time, it was a national service, everybody wanted to do their part and make sure that, because it wasn't just COVID, we also had many other surgical work that needed to be done but couldn't be done in the public hospital. So a lot of it was taken over by the private hospital. We did it. So now the question is, would we be able to duplicate that same arrangement in a way that, look, the funding comes from the National Healthcare Fund. You can get your surgery done in private hospital as well. But, the private hospital, this is where the private insurance companies, they wanted to have the DRG, the DRG, the diagnosis related group, so that they know that, look, at the end of the day, the DRG, I need to only pay 15,000 or 20,000. And then it's supplemented by the National Healthcare Financing Scheme, and then supplemented by the patient's own, like what they call co-payment or something like that, so they can actually get the things done. So it's a discussion that needs to take place, but at the end of the day, it's still very much in silo. We've had a lot of engagements right now with the ministry. The Bank Negara, the PAC, we talked about it as well. But I think everybody's going around with some kind of solution. But the biggest solution that we have to have is the National Healthcare Plan.
Yes.
That would solve the problem.
Yeah, I think I also stand with you on this one because I spoke with Dr. John about this yesterday. So he also talked about it, sort of like a national fund that can, subsidize the current healthcare system.
Correct.
Yeah.
Because the current 1 ringgit, 5 ringgit thing, if I'm not mistaken, the revenue generated from that aspect is less than 1 billion. Could be even less than half a billion, So when you're talking about a $42 billion 100% financing for the taxpayer, and your revenue generated was only half a billion, it's
nothing.
Near nothing. And I think the public, actually, to be honest with you, if you speak to some sensible people in the public sector, they are quite willing to actually pay more. I mean, like, if you're going to be paying, say, 40,000 ringgit for a surgery, and you end up paying only 500 ringgit in the public system, wouldn't the public be more than happy to pay for that?
Yeah.
So we need to have a rethink about some of the things, the discussions. That it cannot be. You see, the problem in Malaysia right now is healthcare is accordingly, like, it's supposed to be free of charge because the taxpayers are paying for it. But it's not sustainable. Why it's not sustainable? Inflation, number one, and you need to pay your doctors and nurses well. I mean, the entire healthcare workforce, I think, is about 200,000. They are almost similar to the teaching and our armed forces and military and all that. That number of people are in healthcare services, 200,000 plus. If you need to make sure that they are happy, they need to deliver a system. They need to be paid well, and they need to actually be encouraged to stay in the system.
Compensated fairly, that's the thing,
Fairly. And what's happening right now is there's a whole frustration with the system. You're not going to see it now, but in 20 years' time, all our good doctors are sitting in Singapore and Europe.
I think it's already happening now, isn't it? Right.
It is happening now. I think the junior ones are going now. So what I'm saying is 20 years. In 20 years' time, all these good doctors will become specialists. But they're not Malaysians working elsewhere. They are not Malaysians working in Malaysia. So we're going to face a big problem in terms of who is left behind, who are going to be delivering the healthcare system, when all the good fellas who are hardworking, who are actually frustrated by the system, they run away. I would say run away. They
go to another country.
Another country that values and appreciates them more. But, the problem is we have trained and invested so much in their training, only to lose them to another country that just takes them just like that.
Oh my God, that's so true. So much resources already put from us.
And so my take on this is just poor planning by the government. We have to accept the fact that it is poor planning. Now, the one time we wanted to have that 1 in 400 ratio of doctor to the public and everything. 1 in 400. We achieved that by overproducing doctors with too many medical schools and whatnot. But we failed to realize that where are we going to put these doctors once they graduate? and the public, what we call the JPA, Jabatan Perkhidmatan, by right, they need to actually understand that these doctors are coming out. We have 3,000 to 5,000 doctors, and many, almost 200, 300 or so colleges recognized overseas where the doctors are coming back. So you have to put them somewhere, and that's why the stopgap measure was the contract service, which became another problem altogether.
Yeah. Thank you so much, Dr. Gunalan, for this
No worries.
this extensive. Actually, I can consider it an interview already, because it's already half an hour. Yeah, I really love listening to you talk, and because there's a lot of things that you shared that really changed my mind about the current industry, And just one more question, probably a bit complex, this one. With all that you mentioned just now, and the solutions that we propose, it being the national funded fund that subsidize the current healthcare system, will this deal with the rate of price increases in medical premiums?
Okay, so what is likely to happen is this, that you will have some cost, some kind of a cross-subsidization, like
Right.
the Australian model I talked about.
Right.
So now the insurer probably will not be forking out 100% of the bill.
Right.
You may have something like, for example, you have streams of payment model coming in. So, for example, say you are a taxpayer, you also have this national healthcare financing
Yep,
scheme.
goes into the national healthcare. Yep.
Right. Okay, you have that. You have access to this amount. So you would like to actually have your knee replacement done in government side, for example.
Yeah.
So you go into the government healthcare system. Probably you'll be 100% funded lah. You don't have to fork out anything.
Yep.
But you need to go back to work as soon as possible. You have no time. I
Okay.
also have invested in my private healthcare insurance. So there is a negotiated rate that is actually taking place in the private healthcare system that pays for a portion of it.
Right.
So that portion from the government healthcare fund scheme comes into the hospital. Hospital will have what they call a provider number. They will be able to get money from there. They will be able to get money from the insurance side. And so in other words, there will be some kind of a control in terms of how much the payout is going to be out. And the DRG, for example, honestly speaking, the DRG system they're going to do only will work if there's a national healthcare financing scheme. It cannot work if you're just going to go like all or nothing. Or I'm going to use DRG on private healthcare. You cannot do that because the DRG, the way it works is basically it's on a model where it is very predictable. And you may have, like, for example, a patient coming in for knee replacement, for example. Okay, he's well, he's not having any other medical problems. He's an uncomplicated stay. Within 3 to 5 days, he goes off. But that is not what we see in the private hospitals at some time. So, you say, for example, you fix a value, say 30,000 ringgit for a knee replacement. That's all I'm going to give you, irrespective of the outcome. So now the private hospital will say, look, now this patient coming in to see me, he's got poorly controlled diabetes, he's got blood pressure, he's got a heart issue, he's going to come for a knee replacement. In order for me to do the coding, I will up-code all of these cases to make sure that, look, he's going to fall into the extreme kind of a charging mechanism, the highest rates, and he may actually end up costing the insurer maybe 70,000, 80,000. For example, I'm just giving you a figure. But if I actually had done what is conventionally right now, what we do what we call a fee-for-service model. So we only will assess the patient. If we need to, we send him to a cardiologist for assessment. The cardiologist will have a look. Okay, he gives a clean bill of health. His diabetes, for example, will be managed by the endocrinologist. She will put a charge for her fees and whatnot. The medications will be given. So everything that comes into it. And at the end of the day, the surgeon does the surgery, he goes off. So the bill may probably be reached about 50,000. But because he had actually considered and calculated all those doctors that need to come in, the fee that you pay is actually a fee for every item that is actually given as a service to you.
I see.
Whereas the DRG model, you're going to, like, even if you're not going to be utilizing the cardiologist, for example, you may end up having to upcode the fellow just in case you end up in the complication. At least you know that you are covered. in terms of your fees and whatnot. So the DRG, you got to be very careful in terms of how you're going to actually implement it, because you implement it the wrong way. Some hospitals may look at it and say, okay, if this one is a too high of a risk for me, I'm not going to operate on this fella, because the DRG will only pay me, say, 70,000, and I expect he may end up having a complicated stay. For example, for neurosurgery or cardiac surgery, for example, sometimes these patients may take up to 2 weeks or even longer, or even may be in ICU for a very long period of time. And if you're going to limit me to say you can only charge 70,000, I will say, I'm not going to do this, send him to the public sector. But this is where the public sector will be strained, because I have the surgeon, I have the facility, I have everything in place, I have the blood bank, I can do the surgery. But because you're not willing to pay me the exact amount of value that I think I need to charge, I'm not going to take the risk. Because if I end up doing the surgery and something happen, and I will now be
liable
by the hospital. Because not only liable from the medical point of view, which is there as well, because you're limiting what I can charge, I may not do all the things that I want to do for you. Like, for example, I may say, I cannot refer to cardiologist, I cannot refer to endocrinologist. Okay, let me just manage this for now. I'll manage it thinking that I'm managing it the right way, but it's not up to the level of a specialist, for example, who are in that particular field. And if something were to go wrong, the first thing that the lawyers are going to ask me is, why didn't you refer to the relevant specialty? And I cannot say that I'm trying to save money for the patient, Because at the end of the day, it's all about what you need to do. It's the standard of care. Again, the standard of care.
To save the patient's life.
Correct. There's a lot of discussion. It's actually very, very difficult topic to actually dissect.
It's so complex.
It's very complex. And if you... I was 3.5 years in the insurance industry as well, so I know pretty much the pain points of the industry. I mean, I sit with the underwriters, I see the claims guys, and I know that these are the challenging things that happens. But the premiums, they are going too far. I mean, to me, my personal take on this is you're looking at one aspect of it, which is just medical inflation. But are you, within your organization itself, looking at what are the things that you can do to improve things? I just look at one aspect of it. Number one, the role of your agents, for example. So why aren't we questioning the role of the agents and all the things that are used to keep the agents happy? They are good agents, no doubt. But they're also agents where sometimes you only see them at this point of sales.
Definitely.
You do not see them after 7 years. And at the 7th or 8th year, suddenly you see them resurfacing and offering you another different policy. So there are the things that are happening because there's an incentive for them to keep you in the system. And they are charging 15% or 10% or 15% commission or whatever. You need to ask that as well. Now, our doctors' charges are controlled. Are the industry rates for the commissions to the agents controlled? And
those are definitely not controlled, I assume.
Yes, and those things that you always see on Facebook, sometimes $1 million roundtable incentive tours to UK, to Munich, to China, they bring all the agents and whatnot. Those are actually adding on to the cost, your cost of delivering the healthcare, which has got nothing to do with the patient care, nothing to do with the doctors, nothing to do with the hospital. You internally have that expense as well that you need to look at. And should you be moving more and more towards automation, digitalization of your healthcare delivery, which they are doing at the moment, which I applaud, but there are a lot of other back-end processes that is happening which are actually very cumbersome and mundane. So, I always like to use this 90-10 principle. Why are you chasing after the 90% of the hospital and the 90% of the doctors who are doing a decent job?
Yes.
Focus on the 10% of the outliers, and these outliers are including both the hospitals and the doctors who are overdoing certain procedures, who are overdoing certain charges. Some of the markups are too ridiculous that you cannot justify it. That is the group that you need to zoom in and say, look, I find that there's something that is not right. Because you see, the data is there and it's quite visible. You're not only seeing it from one hospital perspective, you're seeing 10, 20 different hospitals in the same area. You have the vision there of seeing why is the bill so different from this hospital versus the other hospital. Then you can zoom in and say, okay, and the thing is that discussion has to take place between the hospital and the insurer. Like, look, this is what we have found, and what are the things that we picked up during our audit of your bills and whatnot. Can you explain why is it done this way, that way, or not? And if there's no agreement to actually really look into it by the hospital side or the doctor's side, then you're well within your rights to actually say, look, I think I need to move my clients away from this particular hospital towards a hospital that is more reasonable in their healthcare delivery costs and whatnot. But that discussion has to take place with some concrete evidences. It cannot be arbitrarily you come and say, today I'm going to pull you out of the panel and whatnot because you're too expensive and something like that. No? Because that puts a lot of issues in terms of, for doctors personally, it's basically about patient care. You may have your arguments between the hospital and the insurer, but ultimately at the end of the day, there's a patient that requires healthcare.
Yes.
So you need to look at that person's perspective as well. That because see, when they buy the medical card, right, the promise was that we will deliver the service. You will get payment. You will make sure that you deliver. You will get your care done. And then when you're most sick and you're vulnerable, the insurance will come in and rescue you from.
And also buy early so that it's cheaper. That's what they always say, right?
So all those things that you sell to your client, and then at the point of you making a claim, all of a sudden the whole thing, changes the story, and you cannot pay for this, cannot pay for that. That puts a client in a very awkward situation, and that puts us as doctors as well in a problem, because our focus is only on, okay, how do we treat this patient? And we do our best for that. And we really, honestly speaking, as doctors, we don't want to get involved into the nitty-gritty of the insurance policy, whether it's claimable or not claimable or whatnot. We really don't want to. We just want to focus on what
the
is
procedure
the medical problem,
yeah.
what is the procedure required, and what we need to get it done to make sure the patient is well and can be discharged home. That's what we are more concerned about. The back end behind the scene, we will try to leave it to the hospital and the insurer. But we normally will get pulled in because there's so much of back and forth justification asked of us.
Why this, why that, right?
Why this particular medication is required, how long is it, why, So it actually is a very tedious process. So my 90-10 thing is basically this. The 90% of the doctors who are doing a good job, the 90% of the hospitals who are delivering a reasonable healthcare for you, let the doctors and hospitals do their best for you.
Yep.
I mean, you have the constant engagement with the hospital, and where you find some ambiguity or some issues or whatnot, sit down with the hospital and the doctors and let's have an open discussion. But the 10% who are really the outliers, who are just trying to milk the system for it, that group, please go all out. All out. Just say that, look, because they are going to be detrimental to the overall delivery of the healthcare system, especially for the private healthcare system. Because if they are left unchecked, then it is a free-for-all kind of thing. They will just, nobody's going to check. Okay, let's just do this. Oh, uncle, you have this card, Let me just do this.
Let me just claim to the max,
Yes, the so-called buffet system.
Buffets.
It can happen, but it is not the norm. What's the problem now is a lot of people assume that is the norm in private hospital. It is not the norm. It is not the norm. But because that one or two incidences are blown out of proportion, it makes it appear that all the doctors in private hospital are.
This is why doctors are so burned out,
Because you're trying to actually say no, it's not there, But the thing is, the image that the public have of private hospital is that they come to a hospital to see a doctor driving a BMW or Mercedes, and they think that, look, we are all earning very too much money now.
Yeah.
But see, at the end of the day, we are actually professionals.
Yes.
Just like any other professionals, an architect or a lawyer or an engineer. You can't blame a doctor for trying to earn a decent enough living using his skills and what he has learned over the years.
Yeah.
I mean, the public doesn't mind paying a few $100,000 for a hi-fi lawyer to go and argue the case in court, but they will think twice about paying a doctor a decent amount of money for you to deal with his health.
Doctor, I got another one for you. The one that Dr. John mentioned is that the consultation fees for a GP doctor, am I mentioning right? GP doctor is lesser than a hairdresser.
Yes, correct. No, you're right. You're absolutely right. It's atrocious. In 1997,
it's atrocious,
there was a 10 to 30 ringgit fee for GP has been the same from
Oh my
1997.
god.
So the problem here is now recently there was a talk about increasing it to between 50 to 130 ringgit.
Yeah.
And I saw the comments made by the public on such increase.
Yeah.
And it's very, very sad to see that, look, the value of doctors are actually like very rock bottom like that. It's like, you don't mind paying, like what you said, like hairdresser 100, 150 ringgit to get your hair done. But the doctor who's diagnosing you and trying to get you well, you cannot give him 50 ringgit.
Yeah.
Which is a bit sad.
That is very sad,
And
yeah.
And that is why the doctors have no choice, because the cost of running the GP clinics is too expensive. We all now have our staff to hire 1,600 minimum wage and all the thing.
Yeah.
And you're actually expecting the doctor to charge only 10 to 30 ringgit for a consultation fee.
How are they going to pay their wages?
How are you going to pay? So they have to end up marking up. So this is where the price transparency discussion is actually very difficult.
Right.
It's a difficult topic for us because you know that you're going to put what you're charging. Say for Panadol or antibiotic, for example, is this much.
Yeah.
The public, like what is in the private hospital situation, they do not understand what are the internal things that are
The
built
intricacies,
into
the
that cost.
details,
Yes.
everything, yeah.
Correct. But to them, they look at it, say for example, Panadol is 20 ringgit. Hey, I can get this at the 7-Eleven or the pharmacy for 20 cents or 30 cents. Why am I paying 20 ringgit? So doctor, just give me the prescription, I just go. Okay, so that is a problem because especially for chronic conditions. Now what happens is the patient goes away with the prescription and he tends to just buy it off the pharmacy. And about 3 months, 6 months down the line, he's completely lost to follow-up. So what happens is, who is actually monitoring the patient's blood pressure, sugar control, end organ damage? That is the role of the private practitioner, the family medicine doctors, the GPs. Now, if they go and just use the prescription and go and see a pharmacist and thinking that instead of going to the GP, I now have this prescription, I can just save 20 ringgit, 30 ringgit, I just take medicine only, no big deal. I just want to go and on. Now, what's going to happen is, the failure of this system is going to be reflected when, in 20 years from now, the number of patients with end organ failure, like kidney damage, heart failures, liver failures, all this kind of other organ failure, are going to come into public sector just because for 20 years before that, we failed to raise the GP fees. And we had this situation where the public now goes to the pharmacies and buys the medications.
All these tiny things will quickly add up, Yeah.
Yes. So you are like penny-wise, pound-foolish.
Yes.
In 20 years' time, you will end up seeing patients with poorly controlled diabetes, poorly controlled blood pressure coming into you, and then your government will wonder why suddenly this rate of kidney failure is now becoming so high. Why do we now have to do a lot of dialysis for these patients? Now, dialysis is very expensive affair already.
Yeah. I guess.
But you could have prevented it if you had actually taken the right step 20 years ago.
Yeah, that is so true. That's so true. I guess what I can take away from this whole almost close to an hour already is that everybody has their own interest when it comes to this multifaceted problem, and the doctors, the private hospitals, it is so much more complex than just pinpointing to them and saying that you are one of the factors that are driving prices up. And when it comes to the insurance industry, I have yet to talk to an insurance agent yet, but probably we can schedule another session because Doctor, you were previously in the insurance industry as well, right? Insurance industry, like what you mentioned just now, there are good agents, there are bad agents, right? Those bad agents are the ones that you want to look out for, that you want to be really careful of. Those are the ones that are what we call profiteering, that are blowing the cases up, that are making us feel like, this is a very bad problem. Really thank you so much for this session.
No
It is eye opening.
Okay, good. Great. No worries. Take care.
We speak soon.
Nice to speak to you.
All right.
Take care.
Bye.
Bye.